Yeah,
No.
that is the active camera, so they can see you, yeah, from there.
Now they can hear me.
Yeah.
All right, so the plan for today. So I guess Jonathan, when he asked me to come talk today, I think I think his preferences was like actually for me to talk about, we had 5 years ago, we had a paper in Science on sort of predicting death. And I was like, I'm not going to talk now about a paper that I didn't think about for more than 5 years. So I figured I'm talking about something else for most of the time, just kind of adjacent to the same thing, and then kind of spend the last 5 minutes giving you a few pictures from that paper and actually related follow-up paper that we wrote. And and if they're like more interested in this other part, then the Q&A can kind of actually lead into this. So my plan is to spend 25 minutes on the prenatal paper, which is less about machine learning predicting stuff, which we are not doing. We're mostly using sort of the machine learning predictions for health policy. So at least you get a bit of a flavor of at least how health economy thinks about public policy or health policy, and how what's the use case for not for the doing the prediction, but using the prediction for to do stuff with it. So that's the first paper, and that I'll spend most of the time on. This is a paper that is joined with Peter Connor, that I never met in Sweden, my colleagues Peter Persson and Heidi Williams, and Amy Finkelstein at MIT. So what is this paper about? So what we do here, we look at the introduction of a new prenatal screening technology. Some of you might be aware of it. It's called cfDNA. Before its introduction, when you're a pregnant woman, you want to you potentially worry about, chromosome abnormalities of your fetus. You could have a simple blood test that would give you some prediction of like how likely you are to have like a baby with a Down syndrome or other abnormalities, and then you can decide how to use it. Whether you want to just know about it, do you want to actually go do more invasive testing that is a little bit risky because it can lead to infections and in miscarriages, or not. And what the study, the focus of this study is the cfDNA is basically the same thing as the blood test, but it's better. It's kind of a new technology that got developed. So it gives you still not perfect information. You still, once you get a positive test, it's not clear, and you might want to decide what you want to do with it. But it's much more precise than the earlier measures or the earlier prediction. But it, from a public policy perspective, it costs more. It costs about 3 times more. So the question is like, okay, do we just give it out to everybody and like cover it for everyone and let people do it, or do we want to decide who gets it covered and who doesn't, for whom is like the earlier blood test is like much cheaper, it's enough. So that's the key question. The data is incredible from Sweden. We know basically everything about every pregnancy in Sweden over a period of almost 20 years. And then I think we have like a bit of a staggered introduction of this technology, or at least the coverage of this new technology across different regions in Sweden. So we have a nice research design from an empirical perspective. What I'm going to show you a little bit of what happened, as the technology got introduced, and then I'll try to give you at least the highlight. Again, we have limited time. Give you the highlight of like a very simple model we wrote down and then estimated with the data that one helps us get the economics of what's going on, but also use this model to ask, okay, what would happen if we covered these different technologies in different ways. And the key results are going to be that if you just let everybody get it, which is a little bit like where the US is going in many states, it's great for patients. If everything gets covered, everybody gets more precise information and do stuff, but it's actually much more costly. So actually from you see the measure that we are using, but from an economic efficiency perspective, a much more targeted coverage, just customized who gets it, the extra test based on the initial results is going to actually get much better. And actually the way they do in most Sweden is actually not quite there. So I guess the optimum is somewhere in between. So just a little bit of background, just like in more detail. So we're talking about 3 common abnormalities, like trisomy 21, Down syndrome, and then 13 and 18, which is 2 very rare diseases, much less common than Down syndrome, but still common enough that you can develop a test for them. And there were some of you, there might have been, there were like New York Times article maybe like several months ago that talked about like really bad tests that people kind of gave people sort of prediction that ended up with lots of false positives and stuff like that. That's really for other kind of abnormalities that really sort of are so rare that actually the ability to predict them is so bad that sort of all these products that are sold in the market are just not good yet. This is not what this paper is about. This paper is only about kind of this first three. So, starting in the 70s, the way to kind of handle some of these abnormalities were basically invasive testing. Probably anyone here who at least had kids or consider having kids is aware of it. Like it started with like amniocentesis kind of in the 70s, and then they developed CVS, which was kind of, you could do it a little bit earlier. The good thing is once you do the test, sort of, they get a needle, they put it in you, sort of, and then they figure out, whether kind of there's chromosome abnormality or not, exactly the answer. And then you decide what to do. Do you want to keep the baby? Do you want to kind of have an abortion? Do you want to do something else? The negative part here is that sort of it has a miscarriage risk that, it used to be higher in the beginning, but now I think people kind of say more or less it's about, 0.5%. That you might kind of lose the baby because of infections and other bad stuff that can happen during the test. Starting around 2000, we started developing this kind of pre-screening kind of test, which are kind of risk-free. The first one were basically some blood test and then some kind of ultrasound, like low real risk. They're kind of fairly cheap, so in that sense they're really good. The problem is that they're not perfect. So if it's a prediction model that they use all this prediction to kind of come up with like probability that you have like a fetus with abnormal chromosomes, and then they might be wrong sometimes. So you still have you still have to decide whether you do the invasive testing to get a kind of a definite answer. So that's basically been like the way the system worked, and then sort of within this prenatal testing technologies, they're like the first generation, as I mentioned, is like sort of a simple blood test with ultrasound. And basically most European countries and some of the US adopted like some sort of a two-step program. Basically, let's cover for everybody this. It was not that expensive. In our day, it's about $140 per test. Send everybody to get this test if they want. And then condition on the result of this test, we basically might cover and sort of, or at least advise them about sort of more invasive kind of testing. The second generation, which is the focus of what we're going to start with, is cell-free DNA test. It's basically a new technology that, if I understand right, I'm not an expert on this. It's basically they found a way to isolate sort of, baby DNA from the mom's kind of blood cells or something like that. So basically, it's kind of the same idea. You do this, it's not invasive, so there's like really no risk to the baby or to the mother. The good part of it is more accurate. It's about 8 times kind of, lower of positive rate for Down syndrome and similar kind of improvement in predictability kind of for the other chromosomes. The negative part is like it's about 3 times more expensive. Like in Sweden, at least, the way they pay kind of the labs. They're paying about $580 per test for the new one and $170 for the old one. And the thing is, like, it's still not perfect. So you still kind of end up with like, about 1% false positive rate and 1% kind of false negative rate. So this is where all the black box of the machine learning comes in. So if we are not doing the machine learning here, we are just using this machine learning kind of in the background that generates these results. And then sort of the key question that I guess we're going to try to ask from an economic perspective is, okay, what do? We have this array of potential tests for the patient, great, cover everybody and let me decide sort of what I want to do. But if I'm a public policy kind of, person, well, it's too expensive, I have like a budget. How do I kind of manage this? And the two kind of typical way people in the world are kind of thinking about it. The first one, the US, many places, they're like, okay, this second test is better. Scrap the cost. Let's just kind of, instead of cover people the first test, let's cover people with the second test and let them do the test, and then people who get a positive or negative decide what to do next, whether like they go invasive testing or not. In most of Europe, including Sweden, which is kind of our setting, it's a little bit like more of a nuanced kind of thing. Like, let's first do the cheap one, it's not as precise, see your result, and then based on the result of the cheap one, we'll tell you whether we want to cover kind of the more expensive one. And then kind of once you get the more expensive one result, you can decide what to do. So that's the kind of the tension, kind of high level, kind of across different countries.
Is the universal, is that like opt-in or is everyone getting it?
Well, it's always an opt-in. You're not forcing anyone into anything. So all of it is really kind of that. When I say universal, it's not universal testing; it's universal coverage of the test. And then people are free to do nothing, basically. So it's like in our setting, say the first one, which is basically free for everyone in Sweden. It's hard for us to know perfectly, but it's about 70% of the people do it. So that's, so and all the stuff I'll tell you, it's about this 70%. Like for the other 30 that don't want to know anything, it is what it is. I mean, like policy on, at least on this dimension, policy is not affecting them because even the cheap one that gets covered, they're not getting done anyway. So what happened in Sweden? So until 2016, the anti-screening, the cheaper test was basically covered for pretty much all women in most regions. The way Sweden runs their health coverage, they split the country to, I think, 13 regions, and each region is running its own sort of region-specific policy. They're kind of coordinated, but they kind of vary a little bit. You'll see sort of in the way they cover different things. But all the regions had like a free kind of anti-screening for everybody. And then once you got like you'll see it's a test of it's basically the test results come in of the NT come in as a number, like it's a probability of are you likely to have like a chromosome abnormality, one of the three. The top coded at 1/2, the bottom coded at like 1/20,000. They consider like if they give you the number, but basically they consider 200 or 1/200, like 0.5% as a sort of positive, anything above it. And once it's above 200, then I guess they'll send you an email today and then tell you, hey, why don't you come in and let's talk and try to advise you into sort of thinking about it more and maybe considering kind of invasive testing or not. And if it's kind of not positive, which is below 200 in this case, they're probably kind of not saying anything. It doesn't mean you can't get it done, but nobody's kind of urging you kind of into this. So that was basically until 2016. After 2016, they still offer a kind of DNT screening for everybody. So everybody in our data are going to come in and, as I said, like 30% don't do anything. Forget about them. We have nothing to say about them. The 70% do good. We still get the kind of DNT result. And then instead of sending you directly to consultation and maybe to invasive testing, they would cover, based on the result, the cfDNA, which is more expensive. And then after you get the cfDNA, then it's kind of positive or negative. The cfDNA result tends to be, they must have some other kind of score in the background, which we don't see. We just tell you positive, negative. And then if you're positive, I guess you get encouraged again. You don't have to, but you get encouraged to get the invasive test. So that's and different regions covered differently. The most common one in Sweden across the regions was the idea that this is the NT score. I'll call it Q later. They basically said, well, if you're low enough, we don't cover the more expensive one. We think you're going to be reasonably safe, so we don't need to spend the extra $600 on you. You can still decide to do invasive testing, but it's on, but again, if you want to do symptom, you can still get this, but you need to pay for it, or you just kind of decide to go directly to invasive testing that they cover anyway, but that has the risk. For the high risk score, that's not all regions, but most regions, they actually decide, well, these guys are probably worried enough that they'll do invasive testing anyway. That turns out to be wrong, sort of in the data to some extent, but they think these guys are so high risk that they'll do the invasive testing anyway, so we don't want to cover for them this kind of wasted kind of extra test that is not going to change the decision. Ends up to be exposed wrong, but that's the thinking. So they only covered kind of the cfDNA thing kind of in this middle range of 200 to 250. So again, some regions have it differently. Some regions cover all the people from 1,000 to the top. Some people are like 200 to the top, but that's like maybe 60–70% of the data is here. So what the data, as I said, it's pretty much going to start getting fast. So that's the data is basically all pregnancies in Sweden over almost like 20 years. And the source of the data, you get in our data from this thing like it's an NT database. So anyone who did the NT score, the cheap test, you got the test for us, and then sort of from there you go to a pregnancy register and we kind of follow what other stuff you did, and then did you have a baby in the end, and then any outcome with the baby with the delivery and so forth. And then I think also you can merge it to other stuff in Sweden because it's all kind of connected. So that's the way the scores look like. So this is the histogram of the NT risk scores, kind of across the full sample. So again, a lot of people are kind of super safe. They're like the bottom coded guy over 20,000. The top guys are this is 1,000 and above. So like the higher risk guys, and this is within the 1,000 to the top. So this like it's more uniform. It's about what was it like 14%? So it's about it's about 14% are kind of in this top group. The reason I emphasize it that basically almost everything we have to say will be about this top group because this is like the overall testing rate. Testing rate here, I mean, either you did the extra cfDNA thing, covered or not covered, or you did invasive testing. Basically, almost nobody that is below 1,000 is doing anything. So in some sense, all this policy is not going to affect them anyway. But once you go to the top group of 1,000, then you get sort of a big jump, and it's about 35%, which is valid. You'll see it here. Let me move. I don't, well, anyway, it's fine. Perfect. So you'll see here that sort of this is 200. This is when they declare you positive for the NT score, and above which they get in and kind of do the consultation and maybe cover it in many regions. So you see kind of a big jump on kind of testing around the 200, but even below 200, it's much higher than this guy. So it's like you're looking at like 5 to 10% testing rate, even though sort of they don't consult you to do anything extra and stuff like that. So only action on this guy, but this is kind of the relevant action. Because if you believe the prediction, the objective version of the prediction, 97% of babies with issues are actually kind of in this range. So kind of this sample of high risk NT scores are basically 97% of fetuses, whether they are kept or not, with abnormal kind of chromosomes. So in that sense, that's the focus. Our sample for everything I'll show you will be kind of only the top guys. What happens when we introduce kind of the new technology? So this I'm showing you here two things. So it's the same NT score on the x-axis. This one is the cfDNA screening rate. So this is in the before period. Almost nobody did it because it wasn't really available. Towards the very end of it, it started becoming available without any coverage, and you see a little bit people doing it, but think of this as complete zero. And this is the invasive rate. This is like, for the same NT risk scores, before cfDNA was available, how many people were basically following up with like sort of amnio or CVS. And you see again, you get a consultation, it jumps up, and then as you'd expect, like the higher risk you were, kind of in terms of the NT score, more people did it, but not everybody. So even people at the top, some of them decided to kind of not follow up to the invasive testing. What happens when you introduce kind of cfDNA? You see more people do it, but especially when it gets covered. So this is only for the region that are covering it like 200 to 50, which is like what I showed you before. So there actually it really gets almost full, everybody you get consulted into and covered of, hey, you can get this extra test for free on, 90% of them do this. And then these guys are not covered. They still do some of it because they know they are high risk, so before they do invasive, they want to do this extra test. What does it do to invasive testing? Well, it doesn't do much here. But for this guys, it's a nice substitute. That's exactly here it's kind of the purpose of the policy. I cover the extra test for everybody. Almost everybody does it. That means that they don't need to, many of them get negative. It's still, still the risk is relatively low. We're talking still about like 1 to 50 or 1 to 200. So many of them are going to come back with like a negative test of the cfDNA result. So then they're like, well, then we don't need to risk the potential miscarriage that are coming with invasive. So many of them kind of go down, and this is probably some combination. The remaining 10% is some combination of people that got a positive result, and then some people that they're still worried about false negatives, so they kind of want to make sure, despite the potential risk. So these are the interesting thing going back to the policy is that Even here, you see a little bit of substitution. So the idea of the policy, at least what I would imagine, is that, well, we don't cover kind of cfDNA at the top, because this guy will do invasive testing anyway, so why bother? But you see that even for this guy, even without the coverage, some of them go to the kind of more expensive test, they pay it out of pocket, and once they get the negative result, they kind of actually push down. So actually there is some kind of saving coming even at the top group. So that's the basic story in the data. Now, what the next part that I'm going to kind of talk very quickly through is to be a little bit of a model. Why do we need a model here? I kind of told you all the story. Well, now we want to explore what would happen if we change our coverage policy. So you need to go a little bit out of sample. So we need some framework to do this. I'll give you the entire model in the picture. Very rational sort of moms. Not sure it's true for everybody, but that's the kind of the way we're going to think about it. You come into, everybody gets the NT score, they get a Q. That's like the NT score, the objective risk of are you going to have a fetus with, chromosome abnormality. Then you have a binary decision, do you want to do the cfDNA or not? It could depend on whether they can cover it for you. You might still do it, but sort of, if it's covered, that costs you $0. If they don't cover it, it costs you like $600, so you need to kind of account for that. If you don't do the cfDNA, then your kind of information is still the same, and you come into the next period with Q. If you do the cfDNA, you are becoming a Bayesian updating guy, and then sort of you come in with like an updated probability. Again, it's not perfect because there's like false and negative and false positive and false negatives. So you come into the next period with like a adjusted probability, which can be either higher if it's positive or lower if it's negative. And then you still have another binary decision. Do I want to do the invasive test or not? Given this kind of adjusted kind of probabilities. And once you get the invasive, one, there's a 0.5% that you lose the baby because of miscarriage. And then you get the result of the invasive test, either 1 or 0. If you didn't do it, you're stuck with kind of the same P that you came from, and then you decide, do I want to keep the baby or not? So that's the basic model. Again, we parameterize it, kind of we use the data to estimate it. Again, some of the nice thing that I'm skipping completely is the variation in the data across regions that helps us kind of get a clean research design. Let me skip this. I guess I'm very proud of this picture that basically the model fit with. Basically, we are not imposing too many parameters. Basically, like 6 parameters that are driving the entire thing, and the Q that is varying across thing, and still we fit the basic patterns remarkably well. And what it tells us a little bit, one way to summarize results, it kind of tells us how much people are willing to pay for that's the way economy thinks, like sort of how much people are willing to pay for the cfDNA test. For those who are covered, it doesn't matter because they get it for free. So as long as they're willing to pay something, they're going to do it. Not everybody are willing to pay something because some people, if I'm going to go to the I'm a worried guy. I'm really risk averse because I just don't want to keep the baby if there's like chromosome abnormalities, no matter what. If that's the case, I'll do invasive testing anyway. And if I know that I'm going to do invasive testing anyway, there's no value from the cfDNA because sort of it's not going to adjust what I do, so I don't want to pay anything. But for most people, it's a decision to make, and so there's some willingness to pay, and that basically tells you what the average willingness to pay in the data for this extra information. And once you have this, then you can actually run counterfactual. So I'm going to go through the numbers. I'll just give you an idea of what we're doing. So take like a simulate pregnancies from the distribution of risk scores that we see in the data. And then we can kind of track them based on the different coverage and testing decisions people do in the data. This is without any testing. I'm going to, you can see results basically, how much testing people do. What are the birth outcomes? Did you keep the baby or not? And condition on keeping the baby, was the baby kind of, with or without chromosomal abnormalities and so forth. And then you can map it to economic kind of, object, which is basically, we're going to call it like, both the government cost and the consumer surplus, which is kind of monetized in dollars. So we do it for different cases. First case is like no testing at all. Second test, and then I should emphasize, and the 2 ways that I'm going to think, these are kind of inefficient. What are we not happy from an economic perspective? There are 2 what we call inefficient outcomes. One is that sort of you had a baby. It's a baby with, in general, some people would be more than happy to have a baby with abnormal chromosomes. So we're not making a normative statement, this is good or bad. But if in the model, we know your preferences. We know whether you like or not like sort of a baby with chromosome abnormalities relative to not have the baby at all. So condition what you want. In the model, if I'm a parent that had a baby with chromosome abnormalities, but I'm a parent that actually would have preferred kind of not to have one if I knew that that's the case, then that's inefficient. Because under perfect information, I would have decided to kind of do abortion. So that's one inefficiency. Why would I do it? Because I wanted a healthy baby. There was a good chance I would have a healthy baby. I didn't do enough testing, so I didn't know. So I ended up having like with the baby that I exposed it in one. The other inefficient outcome is basically, these are kind of basically abortions of babies that are kind of fine, that they have no kind of abnormal chromosomes. The reason you have that, like, because you want to make sure you go to the invasive testing. If I knew that the baby is fine, then I wouldn't have done the invasive testing because there's like the risk of miscarriage, but I didn't know it, so I do this, and many of them actually get miscarried because of the, so these are the two outcomes that you somehow you want to kind of reduce as much as you can with the extra information, and these are kind of ways to kind of monetize how important it is for you, because some people, they are close to indifferent between the different outcomes, so maybe they don't mind as much getting one versus the other. Some people really hate one outcome versus another, so actually for them the monetized values is higher.
And these are basically percentages.
These are out of kind of per 100 pregnancies.
Do you know how well this tracks with rates of Down syndrome in?
So we looked at it, it's in the paper, you'll see it's like an appendix graph. It's even though we have basically the universe of pregnancies almost in Sweden, it's still sufficiently rare that it's just too small to be meaningful. It's not like completely
It
off.
seems like rates in the US at least are much lower
Right,
than
but-
rates of chromosomal abnormalities. So like there are far fewer babies with Down syndrome than would be suggested by the percentage of chromosomal abnormalities.
Yeah, well, one thing that like we looked at some of these, so one, the US is very different, also
Sure,
how
yeah.
much people do stuff.
Yeah.
The other thing that these are all conditional kind of getting into our data. To get into our data, you needed to have done the NT score, which basically means that sort of you're kind of at about 11 weeks or something. So kind of all the early, if you look at like say abortion rates, which is like here, it's basically we're talking about small single kind of digit kind of percentage. That's much lower than the typical numbers you'd hear. But these are all kind of, many of the abortions kind of are basically happening much earlier in the pregnancy before this guy. So these are all kind of wanted pregnancies with people who kind of care about it. So not perfectly representative, but so you want to kind of adjust it when you think. But Sweden, US is like
Sure.
completely. So that's just the nature of the exercise, and I should probably speed up. So this is like no testing at all. This is like some kind of benchmark of saying, like, suppose you knew everything without any testing, like, so you cut kind of by design, sort of all the bad stuff, or the what we call inefficient stuff, how much money kind of is on the table. That's like $2,800 per pregnancy in terms of kind of, monetized kind of we call utility or surplus.
Why is the live birth lower in that column?
Oh, because because here you're not testing at all, so you're getting many. So you're basically getting pretty much all the babies, almost, unless you're so worried about kind of baby without no. So even though you didn't test anything,
Okay, so 2.74 is just pushed into the 1.26. Okay.
yeah, some version exactly, some version. Because now you're testing, because now you get more information. Some people decide to abort that before they didn't have this information, so they were like. They thought it was likely they'll have kind of a baby, which is fine, but turns out it wasn't. We're now losing babies in the process, but sort of potentially kind of the right type of babies, not normatively, but for your own preferences. But the two kind of relevant kind of exercises, one, this is like, let's not have the cfDNA, just allow invasive. How does it do? So I guess the one way to read these numbers, I'm going to pick some numbers, is that you get from like, this is the baseline without any testing, that's like the 1960s kind of version. Now what happened, you kind of cut about 90% of the bad stuff, like from about 0.7 to 0.23, from 0.63 to so you get about 90% of the bad stuff. And then if you had like full cfDNA coverage, everybody gets free coverage, so they're still not making, everybody kind of gets it for free if they want to. Then you cut 90% of what's left. Okay, so it's still kind of, it's kind of not crazy. Sort of the first version of technology cut you 90% of the bad stuff, and conditional on what's left, the second version of technology cuts you about 90 extra percent. So we are getting to small numbers, but still, I mean, some people are worried about it. What the focus is like sort of, okay, moving from here to here, that's cost you money. So if you look at government spending, we are talking about, well, it was like 330, only the invasive testing. Now we are kind of saving some as we are covering the cfDNA. We are saving you some money because fewer people are doing invasive, but everybody almost are getting a cfDNA. And that ends up kind of, increasing government costs for this kind of by about like 60%. So the question, can we find some kind of, sweeter point in the middle that kind of does better? The way economists think about this, you put a graph, put government cost per pregnancy kind of on the x-axis. This is like how much people gain, if you will, sort of per pregnancy, kind of on the y-axis. So kind of better outcomes are kind of in the northwest, right? Sort of, I want no spending and a lot of surplus. The two initial cases I told you about is like, one is like no cfDNA, which we haven't had the technology, full cfDNA. It's a little bit like most medical technologies in one, like, introduce a new machine, MRIs, whatever. It's great. We can do more stuff, we can find more stuff, but typically it goes kind of northeast. We can do more stuff, people are happier, but like, either cost the government or the taxpayer kind of more money. So there's a bit of a trade-off how much we want to do this.
From a government standpoint, they're getting a new taxpayer for life.
We don't. Yeah, but also
And for $300, if you can get a lifetime taxpayer, I mean, that's a great deal.
it's also a lot of
So why do governments think this way?
Actually, I have my colleague Pete Cleaner is actually thinking about. It's actually interesting. He has a paper now with Chad Jones at the GSB that are looking at should be, because almost all but now I'm way out of my comfort zone. Like there's all economic accounting, like at the macro level, are all about GDP per capita. And he's like, maybe you should think about like total GDP. So if you get more people, that's kind of good for you. And again, under some assumption, you can measure for that. It's kind of, again, I'm not going to speak to so let me. So just like give me 1 second. So basically, like just to summarize the key results is basically, so within this graph I showed you before, and again, the vertical lines here, that's a little bit like the economic way of saying what's the trade-off between dollar in the government pocket to a dollar in the consumer pocket. Is not 1-to-1 because of some inefficiency of governments, like 1.3 or something. People come up with different conversion rate, but think of this as sort of the conversion rate between dollar here and dollar here. These are the three situations we consider here. So one is like, well, let's cover them only for 200 to 50, which is like the model coverage that I talked about in the beginning. The other one, let's make it available, but not cover it. And this one is basically, let's cover it for everybody, including the top guys. And the nice thing here is, so all these things are better than nothing. All of them better in the sense that they're like both saving money, because now people are shifting from invasive testing, which are expensive, to kind of cheaper testing, and that in many cases saves them to do the follow-up test. And they're increasing. So all these things relative to kind of nothing are improving in terms of like, everybody's better off. Government is saving money, people are kind of doing better. All of them are kind of, there's a trade-off with consumer. Again, consumers would always want to have more cover, but that's too costly. But at least among these three, one, if you believe this conversion rate, all of them are better than just the US version of let's cover it for everybody. And among them, you see that, for example, the covering everybody above 200 completely dominates kind of the 50 to 200 that is currently the regime in most regions in Sweden. In the sense that what I told you in the beginning, because all these high-risk guys, even them kind of would actually opt into cfDNA and avoid the invasive testing if the cfDNA comes back negative. So you can save money there, kind of somehow they were under the impression they want. So you see that sort of, if this compared to this, you're kind of increasing a lot of consumer surplus, you're saving a little bit of money, everybody's kind of basically a Pareto improvement in economic stick.
It's just shifting the cost from the government to the private payer.
No, but the point is like here the private payer is he's happy to pay it because the value is kind of actually higher than the cost.
It's worth it.
Exactly, but that's something you need a model to be able to know, exactly.
But the funny thing is that no coverage is on the same indifference line, roughly.
Yeah. So if you think kind of you want to go higher, so the best one is kind of 1 to 200, and then you can go. Now you're kind of believing the model too much. You can go more granularly. You can go more granularly and start. Okay, let's kind of fine tune the 200 to be something else, and you end up at something like 60. that is again, you're reducing customer welfare, but you're reducing government spending so much that it actually kind of dominates. So that's kind of but that's anyway, that's this paper. Let me skip. I have in 2 minutes. Let me just tee up any potential Q&A on the other papers. So that's I think what Jonathan wanted me to talk about, kind of when he invited me a few months ago. So I'll just give you 2 minutes, and then you can ask questions kind of in the Q&A about this. So these are two papers. It's like a science paper from 2018, which is basically using CMS claims data on fee-for-service kind of medical patients in 2008. I'll show you 1 or 2 pictures later, which is basically trying to predict death. And the key motivation for this was all these people in the news and the newspapers saying, oh, the US is so screwed up because, you know, so few people die and we are spending so much money on the dead. We could have saved all this money. And then we had the issue with this for us was like, it's hard to actually do something which is more nuanced with this because like such heterogeneity on how people die across different type of conditions. So it was hard to actually to kind of homogenize this in a coherent story. So we went to Israel, where we have claims data that is kind of pretty high quality, similar to kind of CMS data. And I think it actually covers actually all age range, not only the medical guys, but actually even the younger guys. And we merged it with cancer registry in Israel. So we had like, we can talk only about cancer patients. And we had like an initial diagnosis of cancer that was a much more natural. You'll see kind of in the first paper, it was like, let's look at a cross-section of people at January 1st, 2008. It's kind of a random date. You know, here, like you have like a much more natural starting point to the prediction model in terms of like, this is the time you got diagnosed with cancer. So that starts your kind of decision-making from a conceptual perspective. So I'll show you a few pictures, then you can kind of, you can finish. So this is the motivation. So this is like different ways to say, there are fewer people, these are the fraction of people who die in a given year, or in a given quarter, or in a given month. And this is the fraction of dollars that are going on them. And you can do it different ways. You can ask, you know, within a year, so some people, but then you can adjust where, you know, if I die after a month within the year, then you only live for 1 month, so I can adjust backwards. So you can say I either spend on them 15% relative to 5% of there are 5% of people who die in a year. We are spending about something between 15 or 23% of the dollars on them. That's the inefficiency. Why we're spending so much money on people who die anyway? And this is like a similar picture in Israel. So the typical and would argue wrong argument is like, this is waste. We could have saved this money. The main kind of very simple point of the paper is like, well, those that end up dying exposed are not those who were kind of basically were sure to die ex ante. Many people kind of, well, they might be sick, but you know, some of them actually survive, and some of them we were able to save, and a large portion, but not all, as I'll show you, of the concentration on the dead people in terms of spending is just because, well, the sick are more likely to die. So if we spend more money on the sick, it turns out that more of the sick die, so that creates this correlation, but many of the sick actually are not dying. So that doesn't mean exposed that it was a mistake to try to save many of these people. That's one way to show the data. So we are doing like, so this is, we are doing like, I don't know, probably not Nigam's type of thing, but like, you know, we try to push our machine learning expertise as much as we can. We do some ensemble to try to predict your death within a year, using kind of throwing everything in the claims data and chronic conditions and stuff on this. And we come up with like what's the probability that you're going to, for every patient in January 1st, 2008, what's the probability you die within the year? And the key point is like, I was actually surprised. Before we started, like there must be some people like, you know, terminal cancer patients, something. We see this in the claims data. We'll have like high probability. It's basically, this is the distribution, like this is the distribution of people. The black is the people, the gray is the gray is people, the black is cost. This is the distribution of people, and you just don't see people who are kind of likely to die. This is the top part. So the top percentile, so the 99 or 99 percentile is like only 4, you know, according to our kind of prediction, is like 47% to die within the year. So that you can't find people who are kind of 90% dying kind of within the year. So talking about why are we spending so much money on the people who die? Well, it's kind of weird, given that sort of you cannot find in the data very easily people who are kind of surely dying. So that's kind of basically the key point of this of this paper, and then the last picture from this paper is to basically say, well, let's look at spending. So this is the spending, this is the p-hat, it's a log scale. So this is the p-hat probability of dying within the next year, and how much we spend on a per person adjusting for p-hat. So now I'm adjusting for how sick you are or how likely you are to die. And of course you see that well, the sicker people are at the right, and we're spending more on them, but again, most of them are not anywhere close to one, so that doesn't mean it's particularly bad. The other thing which was going to tee up the next paper is this is sort of the same picture, but now I'm splitting it within a p-hat to those who end up exposed dying and those who end up, so here there are very few people who die. So these guys are very few of them, there are many of them here, because they come in with these are healthy people with very low p-hats. These are people who are much more likely to die, so there are many more people who are dying here than people who kind of who survive. But the interesting stuff for us was that even after conditioning for how likely you are to die or how sick you are, you still see some sort of a gap between exposed, how much we spent on the dead versus how much we spent on the survivors. So now this is not about the dead or sicker on average. Kind of this is about condition on how sick you are. You're still kind of spending more money. And then again, I'm not saying that's a waste, but that's something that the original story is still not fully explaining. So that did up the next paper, and I'll show you one picture and then I should drop up. So this is from Israel. Now I switch to, you kind of replicate more or less the same qualitative patterns in Israel that I just showed you. Now it's a set of cancer patients. There is an initial, so now instead of starting in January 1st, I started at the date of cancer diagnosis. I rerun the entire same machinery in some sense and create like sort of a p-hat for each cancer patient. And then we ask, why are we spending or how are we spending more on the dead exposed, kind of condition on on the p-hat. And the thing that I guess I like about this picture, so we split the dollars to three type of things. These are all cancer guys. These are kind of what we call inpatient or in-hospital spending, but low intensity. By this we mean that like these are like inpatient episodes that are not coming with like procedures and other complicated, other kind of complicated stuff. Mostly kind of you're kind of you have a bed and people follow you, but they don't do anything to you, and you just stick there either until you get discharged or until you die. So like inpatient high density, these are typical kind of in-hospital patients that are associated with kind of more extra stuff, like procedural surgery, stuff like that. And then like all this other stuff, could be doctor visits, kind of pharma, stuff like that. And then each line here, so these are all dead people or exposed dead people, but every line captures within the year people who die in different months. So they're all month zero for all of them is the month of the diagnosis. All of them are going to be dying by the end of the year. And then but actually each line is, covers kind of, did you die after a month or after 3 months or after 6 months? And what you see here is that sort of, if you count time from the time of, from the, kind of going forward, from the time you got diagnosed, you see that sort of the high intensity thing is all kind of more or less line up on top of each other. So kind of the idea that sort of, you get diagnosed and then a bunch of stuff like a protocol we do, it kind of makes sense, like we do to you. And then, some people survive it, some people don't, and stuff like that. If you can month reverse, like from the time you died and then going backwards, then you see that sort of the low intensity are kind of lining up on top of each other. So it's kind of saying like your last month or two before you die, we don't know you'll die, but they kind of look very similar for many people. It's basically many of them are sitting in a bed in the hospital and then sort of drop dead at a different point, but there is not much happening to them. They're much just, so that's kind of elevates. So in some sense, the process of dying, in some sense, kind of elevates the spending on the death. And the last point I'll say is like, from an economy, like, is that waste? But if we knew that all these people are coming into the world and sort of they're going to sit in there for like 2 months before they die, and they'll die for sure. Maybe it's, I don't know what we do, but maybe it's a waste. I don't know. But many of the people who are looking the same are not dying after these 2 months. So the idea that we can save this money kind of in some efficient, sensible way, it's not obvious at all. So it's more like about the process of dying, but even this process of dying, it's so hard to predict death that sort of it's not clear that you can sort of, so that's the basic kind of story.
How prevalent is advanced care planning in Israel?
I don't know, I have the numbers, but I don't think it's, well, there's like a subgroup of population that has nothing, but I think for enough of the population, I would think it's more like the US. So I think about it the high level, not that different from here. I mean, people ask, you talk about it, you plan it to the extent that you're comfortable with it. So
The US is very bad. The numbers are low 1%.
is that
Yeah.
is that it?
Yeah.
But
The number of humans who receive goals of care documentation in more than 30 days before they die is like 3% or something. And if you ask 6 months before they die, it's 0.08%. The US sucks at this big time. That's why, so we're making mortality predictions to drive advanced care planning, because it's not a good way to save money.
Yeah. We had a project long time ago, it didn't go anywhere, with and again, the argument was something like, oh, if we can identify the people or kind of palliative patients, it's like a win-win. We can send them to better places and we can actually save money in the process.
You can send them to better places, you can't save money in the process.
So that's one question too, like from a data perspective in the US, it's just impossible because sort of the minute they go to better places, then they're not in farm anymore, and then I have no idea what happened. So it was hard to track. But it's still an open question in our head, like sort of we did what we could and we stopped short of kind of having kind of a clear answer. But I'm more convinced now to like, all these statements about, we are wasting so much money on the dead, that's stupid. I mean, that's like, I think it's a stupid statement. So.
Sick people cost more. That's the correct statement.
Yeah, and even condition being sick, we are, death is expensive, sort of, the process of dying is just more expensive than the process of living. I mean, like, and it's not clear, we are not, it's like, what can you do? I mean, people are sick, they sit in a thing, they need monitoring, and we just, it's part of the process. It's just like, so anyway, so that's the second set of papers.
Were there questions this side?
Well, on the previous work, can you go back to that graph, was the consumer surplus versus government spending? So it seems like according to this graph, the fact that consumers are not buying the cfDNA testing by themselves, is it an indicator like irrational, I guess? Or like, how do you explain that? The fact that if the consumer surplus is so high, why aren't consumers buying cfDNA?
No, these are all averages. These are all averages. So well, the model is, well, this is not evidence of anything because this is using the model to kind of predict out of sample kind of, decisions. And in the model, people are perfectly rational. Doesn't mean they are, it just means that that's the way we model them. So all these numbers are based on sort of underlying rational agents that are making decisions. And then again, I'm getting a little bit into the model, but like in this model, what you have, you basically have your utility parameters is basically 3 outcomes. Either you have no baby, or you have a baby with no chromosome abnormalities, or you have a baby with chromosome abnormalities. We are simplifying your life. Life in general are more complicated, but we are kind of, reducing it to only these 3 outcomes. And each person in the data, each couple in the data that have kind of a pregnancy, they are coming to the data with these 3 numbers and decide what they want to do in terms of testing and stuff, assuming they're kind of based on kind of, rational decision makers. So all these numbers are coming from this model. So it's not that of rationality, but the reason that people don't pay for this is because they don't value it as much.
Yeah, but isn't there like a circular thing here, and like this graph, if this graph is correct, that means the value of it is that high, and that they should be paying for it individually.
No, what are you saying that I'm not?
Like if the value is $2,600 to give everyone a.
No, again, this is total consumer surplus from the pregnancy. You're getting a lot of this value even without any test. So the bottom, so everybody, you're making it, so you care about the difference between what your kind of outcome would be with and without the test. That's the payment decision. go back, maybe that's a better graph to talk about, so we skipped it, but. So this is sort of, in the day, after I did the model and got the estimate and everything, for each person, given their preferences and their kind of NT-score, I can ask, okay, how much, given you got the NT-score, you could decide to go invasive. In the process, you could decide how much to pay out of pocket for the cfDNA, which sometimes it's covered, sometimes not, but like suppose you're not, what's your willingness to pay for it? And this graph is basically telling you the average, not for everybody, for each point here, there's like a distribution of people based on their preferences. But this is like the average willingness to pay for the cfDNA test. And what you see here is that for the people at the bottom of again, these are all high risk relative to the population, but the people with the lower part of the distribution, they're kind of safe. They don't think they're likely to have like an abnormal kind of chromosome anyway. So they're not willing to pay that much. So on average, they're willing to pay about $70. It doesn't mean that nobody is willing to pay the full 600, but there are few because like they're only the takes. As you get kind of to the higher risk guys, again, I'm not considering coverage decision here. This is just kind of your out-of-pocket willingness to pay for it. Once you're at a higher risk part, then the willingness to pay gets kind of much closer, like a $400 to $500. Kind of, it gets closer. So now kind of you have like, I don't know, like a third or 40% of the people would have bought kind of the cfDNA even if we didn't cover it. And then once you cover it, then everybody would basically. So if you go back to the previous graph, so I think what was confusing maybe is that these are total kind of surplus, not total surplus from the cfDNA. These are total surplus from the pregnancy. So when you think about, do I want to do the cfDNA? I'm not comparing total surplus to nothing. I'm comparing total surplus to what I would get in terms of expected outcome with the cfDNA results to total surplus I would get without the cfDNA.
Oh, I see. It has to be relative to that other one.
Exactly. So it's all
Sorry,
relative statements.
Hey, Liran, this is actually Jonathan Chen. I'm online. Unfortunately, I couldn't be there. I'm working in the hospital, taking care of some of these patients who are very expensive and will probably die within the next 6 months. But I don't know that they're going to, so I'm still providing my very intensive care.
Perfect. You're consistent.
Make sure they get advanced care planning, Jonathan.
I've seen the notice. I do the counseling. Whether I write down a document that says that form, I don't know if it's worth my button clicks, but yes, we'll work on it. I just see a hand up from Usman Ahmad. He brought a question in the Q&A. I'm just going to try to relate. It was basically something like, nice, UK, they use qualities as a thing to aim for. What do you think about that as an approach to decide what's worth treating or not?
Can you say it again? I heard like half of it.
Quality adjusted life years. Is that a good way to decide whether or not something is worth doing for a patient?
Well, it's better than nothing. It has pros and cons as like most this type of measure. I guess the high level answer I would say, you're hitting on kind of, I think it's a fair debate. So this paper, like the prenatal paper, this what I talked about consumer surplus. This is all what in economics. I think most of you probably have seen some version of it in different parts. It's like the idea of revealed preferences. Kind of you're basically you're using what people do to kind of infer what they like. The quality is basically saying like, screw it. I mean, whether they do or not know what they want or what they like, we know better from them because we're going to measure how they feel at different stages and we're going to kind of price out different sorts of morbidities kind of in a way that is kind of, additive so we can add them up and then come up with a number. I think you have multiple camps. Again, sometimes you don't know, you don't see decisions, especially when you talk about like, I don't know, Medicaid patients, they pay nothing out of pocket. So there's like no economic way to actually infer what they like because they just do what they do, but there's like no price kind of component to their decisions. So the only way to monetize kind of their value or their call it utility is some version of equality or some other metric that kind of looks at their health. But in other cases, when you see people making decisions, there's a bit of a tension whether like, well, I decide to take the bus kind of every day instead of drive my car to work. Does it mean that so some people are like, well, that must mean that you must like the bus. And other people are like, look, no, you're an idiot. You have no idea what you're doing. I know better for you. You should have kind of driven the car. So it's a bit of a paternalistic versus less paternalistic view of the world. And the best cases is like when the quality, when you have the luxury to actually do both reveal preference analysis, like we did in this project, and the quality analysis, like you mentioned, if you can do both and compare and contrast, then if they both lead to the same answer, that's great. If you have only one, you just use what you have, and then, I mean, I think it's fine. I mean, sort of, again, they can get better, they can get improved. I mean, like when you see the sausage making, every time I looked at the quality accounting, it makes you feel uncomfortable. But again, like it's not clear that we have the perfect, so we shouldn't let the good be the enemy of the perfect, or the perfect be the enemy of the good. Yeah, it's also context specific. I think one concern that people have with quality is that sort of you use this stuff for the entire population and then you apply it everywhere, and probably like a lot of context specific that sort of you want to adjust for.
Usman, do you want to follow up?
Yeah, thanks a lot. Sorry. So my background is I studied economics a long time ago at Northwestern, but now I'm a clinical doctor, and now I'm like full-time in research at the moment at Stanford. But yeah, I think a lot of these questions are around whether society is bearing the cost of, like, let's say a treatment or a therapy or a screening test, or if it can be, or if an individual is bearing the cost of it. And I think then it's a question of we're looking at whether a consumer is looking to spend for an extra screening test. But I think like if society is bearing the cost, like in a nationalized system, like in the UK versus the US, in certain cases they would deny, I think they denied the approval of chemotherapy when I was, 2014 or something. It was like a Bristol Myers drug, and they actually denied it because it only improved survival for a few months, but then was like 10 times the cost of, the next best thing. So, from that analysis, using the quality adjusted life here, they basically were like, unless you drop the price significantly, it's probably not worth the patient's, and the government's kind of time, right? But this is a completely different question, and I think it's like a question of metrics, right? A lot of these arguments happen over, what are your assumptions into building the model, and then like what is the metric you're using, to decide whether something, may be viable or not. And so, yeah, I mean, it's an interesting point of discussion. I don't know if there's one right answer, but I think it definitely should be taken into account. Yeah.
So the one thing I flipped to the table, not to get you through more numbers, but the way I'm not very objective, but what I like about this paper is that sort of, in some sense, if you are very skeptical, and many people are, and it's totally fine about revealed preferences per se, like I don't want to monetize kind of the dollars just from one choice. That's kind of too much. I'm not feeling comfortable. That's fine. But if you look at this table, that like the table I kind of flipped through quickly through the presentation, I mean, basically all the picture that we talked about later that use consumer surplus, that's coming from the bottom panel. It's trying to monetize consumer surplus. But if you're one of the skeptics, which is totally fine, then, but again, you still need to believe some version of the model, but more the positive part of the model than the normative part of the model. You can basically say, this is not a model of what people like, this is about the model of what people do when they face different prices and face different decisions. So screw my consumer surplus stuff, just focus on the positive part, which is kind of the middle panel, like the different pregnancy outcomes. And if you want to assign to different outcomes, suppose you come in like, people have no idea, actually kind of, all these people who don't want to have like a kid with abnormal chromosomes, they have no idea. I have two of them and it's a lot of fun and it's a totally valid argument. Just assign different dollar values or different conversion rate to different outcomes, saying like, I don't trust the preferences part, but I still trust the outcome of the model. And then, you can come up with different kind of policy recommendation based on that. So it's all about conversion factor of different outcomes and government money and people's outcomes. So that's what we do. And again, economics is all about trade-offs. It's about how do we trade off these, vectors of different outcomes, and then we need conversion. We cannot say, well, this will go up and this will go down, and we have no idea. Someone needs to kind of put the conversion factors in, and I think that's where the debates come in. And I'm not sure we have like a strong tool to say this is the right conversion factor. There are like many conversion factors that are kind of, admissible, and you just need to, that's a political discourse more than kind of economic discourse in some sort of sense. That was a question.
What are the primary drivers of cost for dying?
So that's what I was trying to do in the last figure. Like, so my sense, at least based on the Israeli cancer kind of patients, is that other than like the sick take more to take care of, that's kind of, but it's also the sick who don't die kind of take more to take care of, is mostly this kind of fairly passive kind of in hospital time. Doesn't mean that everybody who die goes through this, but enough people who die go through like, few last weeks in the hospital before you disconnect them.
So it's just the inpatient stay, or is it like the medications or like painkillers?
It's hard to it's hard to say it's just this. I don't want to go as far as say like it's just this. But the one thing that jumps up off the page in terms of it's really different for the people who die versus the people who don't die is this. I mean the other is kind of more fuzzy. So
And so this doesn't include hospice?
hospice is like just not a big enough cost factor to kind of, at least in Israel at the time of the data. Maybe it's growing, like the US now, like I saw some pictures, like because they incentivize a lot of hospice, so people are now, they go to the hospital and then they sit there for 3 years. Which kind of makes you think that that's not the idea of a hospice, but partly the incentive is so much kind of, hospice that sort of, so but that's recent years, like in Israel, it was just not a big sort of component of the dollars at the time, so it's hard for me to speak.
Yeah, I think hospice relatively is not that costly. Hospitalization almost always completely dominates all other costs. And I really appreciate that study you guys did, because there's such a classic talking point. Half of people's medical expenses are the last 6 months of their life. So we must stop that last 6 months of life. Your study is kind of showing it's not so simple. Do you think it's not that simple, it's complicated? Or Liran, you seem to take a position like that position is just stupid and it should not even be discussed?
Yeah, the analogy that we always use when we're giving talks of this paper was like, you always fall in your last kiran of the day. So we should always avoid the last kiran of the day, and that's not a good advice. So it's the same. I think it's kind of the same thing.
I would go as far as to say, like, based on like Ziad's paper, your paper, and the things we've seen, trying to predict mortality to save money is a dumb idea. I mean, it's just like, it's not gonna pan out, but people just still keep trying.
Yeah, totally. Great.
Okay, we're officially 4 minutes over. Jonathan, you want to close it out? You're here.
Again, just thank you so much, Liran. I really appreciate having discussions. I thought Motivate was some key talking points, gets us to think critically about things that people can have emotional, intuitive thoughts on, but when you understand the data processes, it's not always exactly what you think. And I hope we'll be able to continue the discussion in follow-up. Thank you so much again.
Thanks a lot.
Thank you.
Good.
Did you get a chance to eat before?
You never eat and talk at the same time.
Well, there's still food.